to basically put functioning the context of where we come from in terms of health sciences and medicine. And as you know, in the 19th century, we really had progress through prevention. And that was not necessarily medicine. It was because we got clean water, we got sanitation, and we got better nutrition. And that is an issue all over the world, maybe not at the same time. But the real progress in medicine or in health, let's put in health, was prevention. And I think we need to realize that when we look back. And obviously, in the 20th century and ongoing, what we have seen is an incredible development in terms of the curative medicine that includes emergency medicine so that people survive if there is an accident. For example, in like what we have at my research institution, spinal cord injury. But spinal cord injury was basically not survived 100 years ago. Only in the last century, we started to have people with spinal cord injury to survive their injuries. We have surgery and we have the pharmacological treatment. An incredible development in terms of the curative medicine. Now, the question is, what is the challenge of our century now? As we have doubled the life expectancy through prevention and curative medicine. People now survive cancer, people survive many health conditions that previously were deadly. And the environment, with all those clean water, sanitation, is so that people actually have a good situation, and we have a doubling of life, of the life expectancy. Not all countries yet, but it's emerging. In many countries, we are reaching a high life expectancy. The challenge now of our century is what some people refer to as adding life to years. It's not only about the long life, but it's about the good life. And adding life to years. And what does this mean? What we see here is from the World Report on Aging and Health. We see basically the different life phases. When you are young, you have a high and stable health in terms of your intrinsic capacity, and you have also a good functional ability, what you do in your daily life, what we also call in the ICF performance. At some point, there is a declining capacity, and that is related to aging. It may also be related to having a health condition or having comorbidities or having an injury. So what is the red line? The intrinsic health capacity is declining. The functional ability may still be high. Thanks to rehabilitation, we may still have a very high level of functioning in real life, despite the fact that intrinsic capacity, for example, muscle strength, and many other aspects of our body functions have actually a decline in their level of capacity. At some point, usually 80, 85, you have a significant reduction in intrinsic capacity. But again, you can maintain a high level of functional ability. You can still function in your life at a high level. So the challenge here is of our center is how can we optimize functioning over the life course? How can we put those lines up so that people over the whole life course have a good life, and we really add life to years? I have put it for you again in a flow here, in a flow chart. So you see at the bottom 19th, 20th, and now 21st century, healthy environment with prevention and health promotion. Then in the 20th and 21st century, curative medicine. This has to go on. We have to work hard on having a healthy environment. But then you have now the challenge of the 21st century, which is optimizing function. It's interesting to recognize that the WHO has, in 1948, developed a first classification that actually is relevant for prevention and the curative medicine for diseases. Is the ICD, which you are all familiar, the International Classification of Diseases. And only now, in 2001, which you also all know as much as I do, we have the International Classification of Functioning, Disability, and Health. And we need this classification now as we are entering in this century into the challenge to address optimizing functioning. But what we can also realize that in a way, from a WHO perspective, and I would say health systems worldwide, we see a shift in the focus from disease, absence of disease, or the compression of morbidity as it was called now, to optimal functioning, physical, mental, and social well-being. So there is a shift in health systems in the thinking, and that is obviously related to the introduction of the ICF. So the ICF actually represents a very important paradigm shift in our health system, so that our thinking is not anymore limited to the treatment of disease and to prolong life, but also, in addition, as a second pillar, if you want, to optimize function. Now, it is also then important that if we think about the big indicators of health, and if we want to look at the performance of a health system, we definitely will always measure as a first indicator mortality, as we have seen during COVID. This was the one indicator that was reported almost daily. And morbidity, what type of diseases our populations have, and what are the causes of death. The third indicator now is functioning. So the third indicator that complements morbidity and mortality. As you also may know, during COVID situation, the indicator of functioning was not reported by any country because not one single country has yet implemented functioning in their national health information systems as an indicator that needs to be reported systematically. We expect this to happen over the next years and decades. Now, let me put a question to you. Obviously, it's a rhetorical question, but I nevertheless would like the question to ask, what is the health strategy that aims to optimize persons' function? And I don't wait for you to answer this in the chat, but the answer is too obvious, but it is rehabilitation. So rehabilitation is the one health strategy that aims to optimize functioning. So we, as rehab professionals, physicians, physiotherapists, occupational therapists, speech therapists, language therapists, social workers, we share one thing in common. We actually are committed and responsible for one of the big health strategies, complementing prevention, cure, which is rehab. And we have a very, very clear goal. We want to optimize persons' functioning. That is what unites us. That is by our common understanding. Now, if the challenge of the 21st century is to optimize functioning, we have argued then rehabilitation is the health strategy of the 21st century. You see the point? We need to optimize now functioning. That's the challenge we have, in addition to curative medicine, prevention, and so on. And that means rehab needs to become the health strategy of the 21st century. So it becomes a very important strategy. And this argument was made during the Rehab 2030 call for action in 2017. I have had the opportunity to write a paper for this Rehab 2030. It's cited in the note from WHO. We called it Rehab, the health strategy of the 21st century. WHO was a little bit more careful. Professor Alain-Cossier said, rehab key for health in the 21st century. But nevertheless, WHO has really taken this up. The rehabilitation is really the health strategy of the 21st century, or is a key for the health in the 21st century. You see here this very important event in this beautiful room, in the executive room in Geneva of the World Health Organization. And you see in the middle here, you see Dr. Ala Kosieza, that actually leads the rehabilitation and disability team at WHO. And you see Professor Gerold who is the father or the brain of the ICF. And I was very happy to be there and to see many of the ideas we have in rehab medicine actually to be realized. Now, Ala Kosieza, the leader at the WHO team, she was not satisfied. She was not satisfied with us, I have to say, with us, the rehab community. She said, she questioned, and she wrote a very famous paper, Rehabilitation, the Health Strategy of the 21st Century. Really, is this really the case? And she said, is the field of rehab, with all its stakeholders that you are now represented here during these webinars, are you really ready to address that challenge? And I actually put that question to you today again. And she said, if we want rehab to become a political priority, all the rehab stakeholders need to bring together their views on rehab under one concept, a unifying concept which is functioning. And also, she said, we need a unified advocacy by rehab professional groups so that we will not have to work in silos, so that each profession works for themselves only, but we actually have then a unified voice or a unified advocacy. And maybe we can discuss that later after my presentation. What is the situation? Where is rehabilitation in Malaysia today? What is the common understanding of rehab by stakeholders? Is there a common understanding of rehab under the concept of functioning as suggested by Ala Kosieza from WHO? Is rehabilitation a political priority in Malaysia? Or can it become one? And how can it become a political priority? And is there a unified advocacy by you, rehab professionals and users? So let's start some considerations on the common understanding. Recently, Dr. Chiesa was invited to our university because she became she got an honorary doctorate from our university. And she said, what is very important for this common understanding of rehab under the concept of functioning is conceptual clarity. Only if we have conceptual clarity, we can advance rehabilitation. Some of you may think, oh, functioning is a theoretical, it's a concept, it's a classification. That may be, but it's absolutely fundamental if we want to advance rehab, that we have this conceptual understanding that we share. And you see to the right side, this is the PowerPoint that Ala Kosieza showed, functioning at the top. And she said, functioning is the umbrella term for all those concepts that we care in rehabilitation, from breathing, seeing, relationship, dressing, you see them all. Actually, conceptual clarity was always was very important to Dr. Chiesa and actually myself and former president of ISPRM, John Melvin. In 2007, so 10 years before there was this call for action, we have written a paper on this conceptual foundation of functioning for rehabilitation, and you can read it for yourself. But ultimately, this was the idea that we can now define rehabilitation based on this concept of functioning, because functioning ultimately is nothing else than the strategy that aims to optimize functioning or to optimize functioning of people that experience or are likely to experience in the future disability. And this is always in the interaction with the environment. We cannot just target or treat the patient. We always need to understand the patient in the interaction with the environment. I know I'm telling you things you do every day, you know it all, but I wanted to bring it back for you again to reflect on it. This definition from 2007 became then basically the basis for the current WHO definition, which is a very short one, a set of interventions designed to optimize functioning and reduce disability in individuals with health conditions in interaction with the environment. Now, the next question I would like to raise and discuss with you is rehab a political priority? I don't know, as I mentioned, I'm not fully aware about rehab today in Malaysia in terms of political priority. For example, I don't know whether in Malaysia there is a national rehabilitation strategy or a national rehabilitation plan. So I will review with you what WHO has done and how this can inform the priority setting of rehab in Malaysia. For example, in Switzerland, we used this WHO resolution, the first resolution in 2023, last year, actually to raise the attention for rehabilitation in the parliament. This resolution really is fundamental. It's the first resolution on Rehabilitation ever in 2023. Imagine all countries of the world coming together in the Palais des Nations, in the Palace of the United Nations. And this is fantastic. They unanimously, all the countries said, we must strengthen rehab in health systems. And this is an incredible political priority setting for all nations. So we rehab professionals can use it. We can actually now, rely on this resolution to strengthen rehabilitation in our countries. The resolution actually urges the member states to take this seriously. You do not ratify, you are not going to give a signature, but you urge the parliament and the governments. The resolution invites civil society, which is, for example, the International Society of Physical and Rehab Medicine that works closely with WHO, to contribute. And it requests the Director General basically to provide the resources for the countries. Like Dr. Ciesa, who is responsible at WHO for rehab, she develops many packages, like the package for rehab interventions, that can be used in countries worldwide. When you look at the resolution, Dr. Ciesa always says it's a beautiful resolution. And I hope maybe, Professor Julia, you could send the resolution to all participants, or Maslina. It would be so great to read this resolution. It's really a beautiful resolution. I'm not going to go through the whole resolution, but I point few things out. The first is when you start a resolution, WHO always recalls previous resolutions so that we have the memory of what WHO has already decided and what is actually there. And very importantly, in the resolution for rehab, is being recalled the resolution for the ICF, which provides a standard language and conceptual basis for the definition and measurement of health functioning and disability, and obviously for the definition of rehabilitation. If you look at the resolution, there is 9 issues or goals, or you could call them recommendations, very normative. And they make all sense, at least in my view, they make a lot of sense across the countries I collaborate with, and they are to raise awareness of and build national commitment for rehab. For example, a national strategy to strengthen financing mechanisms so that we have rehab being covered from the district level to the tertiary care level. Expand rehab at all levels, and here I will show that later. Malaysia is a model country. You actually have services at all levels, as few other countries have, and so on. I'm not going into the details to not lose too much time here, Under the point 6 here, we need to ensure that we have functioning data that is based on the ICF. Only then we can strengthen rehab in the health system. And that means we need data on functioning in clinical practice. We need it for service provision and quality management, national quality management systems, and we need it for policy making. And obviously we need then research and so on. Now, I have said that I would be very interested in the Malaysian perspective and in the discussion to learn more of from your viewpoint. Now, in my understanding, Malaysia is a model country for the development of rehabilitation, as I've seen during my visiting professorship, scholarship here in 2017. What we are all puzzled worldwide to see this incredible emergence of rehab medicine from scratch in something more than 20 years. And this is the pictures, I think, from the first batch, as it's being called, with Professor Zalia Omar and first graduates in 2001 and 2001 and 2002. And now we are 139. And this is incredible. I talked yesterday to Professor Rory O'Connor from UK, and I told him this, and he was puzzled. He said, you know what? In the whole UK, we have very few more than now you have in Malaysia. So we have a fantastic situation in terms of capacity. And this capacity building has been acknowledged and is being referenced in an international effort to advance academic capacity in rehab medicine, or by 3 organizations: the International Society of PRM, the European Academy, and the Association of Academic Physiatrists. And I'm very grateful to our Malaysian colleagues that have contributed to this paper and actually have told how you develop academic capacity and how you implement rehabilitation system-wide in a country. It's a model for many other countries. Now, the question is, where is Malaysia in terms of spearheading the implementation of function? And that means, where are you at this point in the implementation of functioning as this common denominator in clinical practice and the healthcare system at large? As we have heard, the integration of functioning in clinical practice and health system is fundamental for the strengthening of rehab. And I would say, if we want to take advantage of the resolution and the political priority that rehab now can have, then we need to make sure that we clinicians use functioning in clinical practice as our basis, and we implement it in the health system, for example, in national quality management, when we benchmark different rehabilitation services. Not going into this in detail, I only wanted to show it. So this is a systematic approach. If we want to contribute to the integration of functioning in the health system, we can actually look at the 6 building blocks from WHO: health service delivery, health workforce, health information systems, essential interventions, financing, and leadership and governance. And under service for delivery, you see obviously people-centered care and so on. So if we want to be successful, rehab has really to contribute or to make sure that functioning information is used at all levels in a health system across these building blocks. In terms of what I understand, in terms of clinical practice, it's well established in Malaysia. I have been with Dr. Siesa in Malaysia, I think almost 20 years ago, invited actually in Putrajaya to introduce the ICF and ICF-based clinical practice. And what we have seen, that you were actually well ahead of many of us, and that you use the ICF as a conceptual framework for clinical practice. So I'm absolutely not here to tell you anything new. You have done that probably much better than we have done it and many other countries that have done it. I would like the attention now to an opportunity that arises from the implementation of ClinFit. This is a tool, the Clinical Functioning Information Tool, which is actually a tool that has been now, or is being developed and is propagated by our International Society of Physical and Rehabilitation Medicine. It's a non-proprietary tool. It's in the hand of all of us. It's not like the FIM where you have to pay. And it's actually being developed in many different versions. It's like as a mosaic tool because it is based on the ICF. So it's actually a tool that brings the ICF into the clinical assessment. And to give you the name, we have the clinical, CLIN stands for clinical, F for functioning, I for information, 2 for tool. So the ClinFit information tool. And I'm not going into it. I would just like to say that there is a ClinFit committee at ISPRM that is co-chaired by Professor Masahiko and myself, and is very much supported by all the presidents of ISPRM. And in the committee for Malaysia is Professor Julia Enga Kazan. So if you have any interest and any willingness to collaborate with ClinFit and the ClinFit committee, we would be more than pleased. And I would also like to give the regards from Professor Fari Khan from Melbourne, where I have been visiting her last week. She's one of the future presidents. She's now becoming the president-elect. And she's absolutely committed to support a regional ClinFit community with Professor Masahiko Mokaino in Japan, with Melbourne, with Malaysia, and other countries. So I think there is really an opportunity now to develop and implement ClinFit as a tool that can be tailored to the specific needs of any services, any type of rehabilitation service. One interesting development that I would like to bring forward to you is in Europe. Our European professional organization, under the leadership of Professor Zampurini, you see the name here, has developed what we call the Individual Rehab Project. And the Individual Rehab Project is actually based on the management of functioning. And it is a very systematic approach how you can use functioning in rehabilitation. And again, this whole idea, the rehab cycle, many of you are full aware of that and have introduced it in many ways. I just wanted to mention that this is still an ongoing idea, the Individual Rehab Project, based on this rehab cycle idea, using functioning as an information. And I would be also very interested to hear from you what is the current state of how you actually structure the rehab process in Malaysia nowadays. Now, if we look at the implementation of ICF in the healthcare system, one very important aspect is national rehabilitation service quality management. Some countries, like my country in Switzerland, but also Australia, and to some extent United States, and I guess some other countries, have implemented a benchmarking system that would allow to compare how services actually provide rehab and with what results they provide rehab for certain population groups. And one opportunity that now arises is the system-wide implementation of national quality management systems in an international effort. I have talked to the Australian colleagues, the Swiss colleagues, or the national governments. They are very interested to actually host a workshop in maybe in 2026 in February on how we can implement such national quality management systems based on the ICF. And I would be very happy to discuss that with you. And tomorrow I will have the opportunity to visit the University of Malaya Medical Center. And I'm very much looking forward to this discussion. Indeed, Malaysia was the first country that actually has developed a framework for such a clinical quality management for rehab that is across all types of services. No other country has that. I show you here. So Malaysia was the first country, in my understanding, that has ever published a systematic approach across all the rehab services, from acute care, general post-acute, specialized post-acute, general outpatient, specialized outpatient, primary to vocational, always with ICF standards like corsets and so on, that would allow to develop a very good approach to develop a national benchmarking system using functioning data as outcomes. Indeed, the European colleagues have taken the Malaysian framework and this initiative, and 2019, 2 years later, have published a similar approach for Europe. In Europe, we found that there is 14 rehab types, including such things like rehab in medical health resorts, which were not in your services types, or rehabilitation and social assistance, or rehabilitation services at home. You see, so there were a number of more services that we found in Europe, not in all countries, in some countries only. So we have 14 types. And as in Malaysia, we actually had then the standards based on the ICF, what needs to be documented in terms of ICF functioning for each rehabilitation service. And the Europeans then called these ICF standards the clinical assessment schedule. What do you need to assess for each service type so that you would provide all the information? I would also like to emphasize that the reporting of the data based on ICF measurement, whether it's the qualifier or any other measurement, is resolved. We now know how we can put the data from these measures that are measured on an ordinal scale, how we can put them on a 0 to 100 metric that has cardinal properties, that is interval scale, so that we can then do proper parametric analysis. We had a big project with the Swiss National Science Foundation and the National Quality Management Agency, and we have demonstrated that any instrument, whether it's the FIM or whether it's another instrument, can be reported on a 0 to 100 common metric. So the technical methodological solution that would allow then to the comparison of functioning outcomes is now resolved, and we are now challenged with the implementation. My last point is the unified advocacy by rehab professionals. And here I would like to invite you for a webinar, or we will have a workshop that is going to be streamed online in Lucerne, my university, on February 16. It's a workshop that actually has the goal of advocacy. We want to highlight functioning in the context of an aging population and rehabilitation as the relevant strategy. And the National Academy of Medicine of the United States is the partner of this workshop. So you see here the date, and there is going to be 5 panels. We will have first keynote lectures on live stream with Professor Gerold, the father of the ICF. He will talk on the functioning revolution. And then we will have Professor Alarcos-Chiesa from WHO. She will talk about WHO's perspective on rehab. And then we will have 5 panels, including one of research that is going to be led by Professor Julia. So if you have an opportunity, and if I'm not sure whether the department heads will allow you to attend some of the panels or at least the keynotes on the live stream, we would be extremely pleased, because we think that from an advocacy perspective, from a unified view on functioning and rehab, this is a wonderful opportunity. And it is, for me, was a wonderful opportunity to talk to you. And I'll now give back the word to Professor Julia and Professor Maslina for the discussion.
Thank you, Professor Stucki, for your lecture. right? And now I would like to invite any question from the floor, from the audience, the virtual audience, right? You can either write your question in the chat box, or we can allow you to speak as well. Yeah, I think our work on functioning or using ICF to collect data started in 2017, as what Professor Stucki said, but it reached a stop, for temporary stop because of COVID. Yeah, so now we are picking up the pace again. So that is why I have asked Professor Stucki to provide this lecture again, because I think we have lost momentum because of COVID. Yeah, right. So is there any question from the floor? Right, I think this is quite a high level discussion or a high level lecture on trying to get the concept of, you know, how we can strengthen rehabilitation in our local context, right? And if any of you want to answer Professor Stucki's question, where are we now, right? Where are we now? Yeah, we have started. Yeah, we just need to make it to continue moving and make it and move together. I think that's the main thing, to move together. And while waiting for others to ask questions, please ask questions. Professor Stucki, what have, you know, we've been advocating using functioning data and to change a policy, or to see people, to help the people to see how important rehab is. Can you share of an example from any country that have done it in a way successfully? Yep.
Yes, I think that at this point so we have to look at functioning on the one hand and rehabilitation on the other. So I think functioning now in many countries has been involved in disability evaluation. For example, the World Bank has funded a number of projects across the world, how you could use an ICF-based assessment for disability evaluation. So who gets a disability benefit, or who would who should get rehab, and so on. So the disability evaluation is one example, and one is, for example, Greece, or one country that has done it very, very well is Taiwan. I think Taiwan is very, very advanced in this. In terms of functioning in rehab, Germany has in the law, you cannot send a patient to rehab without doing a functioning assessment based on the ICF. So it's a law that you cannot send a person to rehab. So that is another example where you see a concrete implementation. Also, Germany has used functioning information for financing for the DRGs, diagnostic-related groups. So in the financing, in many countries, you have DRGs that are based on the diagnosis, the interventions. And when you have elderly patients coming to hospital, they have maybe a disability pre-existing, then you cannot have a good reimbursement scheme with disease and intervention only. So you have now, in terms of rehabilitation, it's very interesting in my country, when we went to the politicians about the resolution, one politician told me, Professor Stucki, don't worry, all good, all good. We do it we have these rehab hospitals. And I told him we need rehab in primary care, like in Malaysia. He said, oh, that's an interesting point. And what I have to say, that most countries that develop rehab do it in the first rehab or in the post-acute rehab, but not in the community. And politically, rehab in many countries is like what some people have said, like a submarine. It has not yet been seen the air. It's undercover. It's not yet a political priority.
Yeah, I think it's the same here for, it's not yet a political priority, but I feel that, I mean, aging is a political priority, and I think it is good because we can use it to prioritize rehabilitation as well. And there is a question here from Richard. Right, so how do we convince medical insurers to reimburse the cost of rehab services in Malaysia?
That is a very good question, and I have to say, for a long time, as I was very ignorant to that question, so I have to apologize. But then came Alar Kostiesa from WHO, and what she says, so the fact that rehabilitation is an own unit at WHO is very important. And it is only a unit because the Director General, Dr. Tedros, has said rehab must be under universal health coverage. It's not something that you just have as an some possibility. You pay or you do not pay. Rehabilitation, according to WHO, is part of universal health coverage. So, to make the answer very clear, I think at the political level in Malaysia, one should argue that if rehab is not being paid, is against what all the WHO and all the countries should do. That has said, it's part of universal health coverage. Rehab is part of universal health coverage, must be part of insurance schemes. So I would say it's a political decision ultimately, probably, is a political decision. And that brings me to the point, how can we use this? How can we use this resolution? Personally, I think to use it for this reimbursement issue is a very important one. Absolutely. So I'm very grateful for your question. And one more point, go strategic. Go strategic. I'm not sure whether we will be successful, but we have a group of parliamentarians from all parties. We work together and we tell them, we will put it to the parliament at one point, all together. But I'm not sure how it works in Malaysia, but I think it's better to have a joint effort, and actually involving the insurers and the rehab providers, everybody, all stakeholders.
Thank you, Prof. Stucki. So it is still something that Malaysian have to work towards, yeah, because we don't have universal health coverage, yeah. And I think Professor Lydia mentioned that, my opinion, there's a mismatch of what is practiced and what is in the paper. We need to find a balance. We are still struggling with concept clarity. Well, I think
I very happy to hear to see Lydia here. So I fully agree. And you see that Professor Bickenbach always says in this situation, there is a concept which is called progressive realization. Progressive realization. Nothing is perfect from the start. And it's absolutely true that you write these papers, it's like you throw the ball in the future and then you try to catch up. It's like when you have the dog running behind the ball. But you need to get into this discussion, and we need also to develop this conceptual clarity, and we need to develop demonstration projects so we can learn from each other. So, for example, the Europeans have learned from the framework from Malaysia, absolutely. When we presented the Malaysian framework to the Europeans, they said, we need that. That is exactly what we need. Nobody had this idea. So basically, that was one of the things. And also now in terms of quality management. And one point I would like to make, Lydia, once you have to construct the quality management system, once you have to measure it, like we have in Switzerland, we need to measure it for this benchmarking, then you have to become very precise. So because once you have then data comparability, you need to be precise. So I think practice is the best motivation to challenge conceptual clarity, clinical practice, but also quality management.
Right. Thanks, Prof. Stucki. And there is Punita. Punita asked a question, but I think more of a practice question, right? Specific challenges to unify among rehab fraternity, PT, OT, and rehab physician. How do you do it? I mean, I'm not sure if a question that you'd like to answer, Prof. Stucki, or we can rephrase the question like.
Oh, it's a very good question. The
Yeah.
problem is I don't have the answer. No,
And how do you think?
WHO has tried. So what WHO has now started is the World Rehab Alliance. You find it at the WHO webpage. So the World Rehab Alliance, what Professor Ciesa, Dr. Ciesa always says, you rehab professionals have to work more closely together. And that is a problem in many countries because there is competition between the professions. There is between the doctors and the, let's say, PTs, and then there is this. So one answer is I have. So at my university, I started a new faculty in health sciences and medicine. And we have three pillars. One is health science and policy, one is medicine, and the third is rehabilitation sciences and human functioning sciences. So one of my dreams is that we establish what I call the rehabilitation sciences as a scientific umbrella for all of us, so that we don't only have then PRM science or physiotherapy science or occupational therapy science, but rehab science. Rehabilitation is a science that is for all of us. So if we work together in rehab science, and I also have started a journal, the journal, which is called the Journal of the Frontier Journal in Rehab Sciences, and I did choose the name to try to bring the rehab professionals together. Absolutely. So, but in the reality, I would be very interested how you do it in Malaysia.
All right. Okay, so just now you called an invitation for those who are present here and how they can propose any type of research or work with regard to clean fit, right, Professor Stucki?
Oh.
Yeah. So I would ask if any audience want to know how can you collaborate with with the ICF or the Clean Fit Committee of ISPRM. Is there any question or anybody who is interested who want to ask more? You are invited to ask more, right? And I suppose if we are all, I think if we are all interested or focused on functioning, I think this is functioning research. I think this is one thing that can also unite the different rehabilitation discipline together. Yeah. No more question. And Professor Stucki, for when just to clarify, when you said let's say there is I know there are speech language therapists here. For example, they want to use clean fit in dysphagia. This is something that, let's say, a few speech therapists in the whole Malaysia want to use that, and they can, if they need some advice or collaboration with the Clean Fit committee, we would encourage that, right?
Yes, yeah, absolutely. So CleanFit is a tool for every health. Actually, CleanFit is supposed to be a tool for every health professional, for any health professional, not only for rehab. And CleanFit can be tailored in very different ways. You decide which functioning domains. You decide which response category, 0 to 4, 0 to 10, and so on. You decide on whether there should be only a clinical assessment or also a patient reported based on questions. This is all possible. So yes, absolutely. So I think that CleanFit should become a shared universal tool because it's actually nothing else than putting ICF in reality. And what at this point is only existing is instruction video or CleanFit COVID. So if anybody is interested, we can send you this instruction video for CleanFit COVID. And over the next years, Professor Masahiko Mukaino and the CleanFit committee now want to develop a manual, a very short manual. But again, it's only a manual that is a starting point. You can always develop your own manual based on that model. So CleanFit is a very flexible tool. And don't worry about the reporting of the data. This can be done using rational analysis or machine learning. So the methodology to compare data is what I call data science. And Julia knows that I think we need now also to collaborate with people from data science, not only statistics, we need people from data science. So it makes life for us much easier. And maybe, Lydia, that would be an opportunity to go in the concreteness of data science. Then you have to specify everything.
Right. So there is, I think we can afford to have one last question from Dr. Aisha, I think here. Are there any efforts to collect ICF data sets across multiple countries collectively? I think you can give example of COVID-19, I think, yeah.
Yes, no, this is a very, I mean, Professor Masahiko Mukaino had this dream of a clean fit day many years ago. Then came COVID, as Julia said. And now we will have the clean fit day is not yet clear, maybe in November. So the idea of the clean fit committee is that we will collect clean fit data all over the world in all types of settings, all population data, patient populations, like a snapshot. And those that can actually do 2 time points, like at the beginning and at the end of this, and maybe also ask some additional questions. But it's really the idea to develop this metric, the common metric, the ruler, if you want, the ICF ruler, that we can then use. So a starting point. And Professor Masahiko Mukaina is very willing to collaborate. I mean, the CleanFit committee, and he's leading this project on the CleanFit Day, is very willing to collaborate. And I would be very happy the CleanFit committee members are very happy to support that.